Hello and welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice-changing evidence for the working hospitalist. Today on the show, I'm joined by Dr. Austin White as we delve into recent studies on a couple of hospital medicine controversies. Should we be treating asymptomatic hypertension in the hospital? Should we be giving antibiotics to patients admitted with pneumonia in a positive viral panel? Well, Dr. White, thank you so much for being with me here today.
Thank you for having me. This is my first time ever doing a kind of podcast, so this is very strange.
Oh, well, it's an honor and a pleasure to have you on board with us. For the audience, Dr. Austin White is one of my colleagues, a rapidly rising superstar in my division, and an excellent clinician, a very thoughtful provider, and also my official designated near-peer mentor or mentee. And so glad to have him on the show. He was willing to humor me and join, probably just from that mentor pressure.
There would be bad reviews if I did not join.
Austin, anything else you think the audience needs to know about you?
So I'm one of the newer hospitalists. Recently graduated, so using this opportunity to continue to stay up to date. I'm excited to be here.
Well, again, thank you so much for being here, and I look forward to it. I look forward to another thing of note is Dr. White does a lot of nights with us, and so I'm excited to have, particularly on these articles, particularly on this first one we're going to discuss. I'm excited to have a nocturnist's perspective on this, or a semi-nocturnist. And in that vein, Austin, have you ever gotten a page overnight from a nurse that says, Miss Jones has a blood pressure of systolics of, let's go, 204?
Oh no.
Anything in that range sound like something you've ever had to deal with?
Every single night.
Yeah.
Yes.
All right.
Maybe not that high. That high is a little bit too high, but every night I'm constantly paged.
And we'll talk more about this, but when that first digit gets to be a 2, it's like, I mean, for me, I mean, everything changes a little bit, and how comfortable I feel and how strong I feel in my dogma. But what do you do? What do you do when you get that page? What's your go-to response? What's your go-to reaction?
Yeah. So whenever I'm chatted that blood pressure, I always ask, are there any symptoms? And usually it's a no, and we'll move on from there. But yeah, it's a constant question from nursing.
Yeah.
To do.
Yeah, agreed. I kind of have my, like I said, kind of my rule of thumb, honestly, in the way I genuinely practice is I can be pretty, if there are no symptoms. So yeah, that's always my first question is like, are there any symptoms? I'm looking to see, like, is there anything about this patient that they wouldn't be able to tolerate a blood pressure that high, or anything going on that this needs to be treated urgently. But kind of my go-to is, as long as that first digit isn't a 2, I feel pretty comfortable holding the line. I say, let's like restart their home orals, or even I'll say, let's get them started on something a little bit oral just to do something, just to make, honestly, to make myself a little bit, but mostly everyone else feel a little more comfortable. The patient and the nurse feel a little more comfortable that we're treating it. So I'll usually throw maybe something oral at it, but certainly, and that would be like starting them on a daily oral at the most. But when I hit that first digit of 200, I probably, if it's long as it's just barely over, I'm probably doing like a PO carvedilol and then sort of scheduling it and planning on it forward. But once that first digit gets to 200, I'm like, the fighting, not treating it is not worth it to me. And whatever risk, like I perk up a little bit, and so I feel like I have to do something. Do you have a limit?
When I start getting more invested or interested in the number, it's definitely got to be like over 180, and then I'm like, okay, maybe I'll consider being more aggressive in treating it. But at some points at night, it does feel like you're just treating the number, and you're treating the myself as well as staff, as opposed to really treating the patient sometimes. If you're for some of the numbers that I get paged about. But yeah, usually I'm not kind of treating or investigating more aggressively if it's under 180. But my number, yeah, would be about 180, and then I start looking into it more.
And I think a lot of our sort of default order sets that you can order as PRNs for hypertension, 180 is usually the number. And I think our order set that like page MD if greater than is probably 180. That's kind of like my
Hmm.
so I think of like the default number of like you're getting a page if it's higher than that. And usually the nurses are pretty good about we don't hear from them if it's not more than 180.
Speak for yourself.
Depending on the nurse.
So
Uh,
at night, it's definitely a different ball game. Where if it reads red in their kind of vital sign sheet, I'll get paged about it usually.
yeah,
So there's a lot of acknowledge the message for 160, 170, and I'll give a thumbs up. But if no symptoms, I'm less interested. But at night, you definitely get paged more
sure.
regarding those numbers.
Um, do you put any PRN antihypertensives in your default order set, or is that ever, routinely something you're ordering for patients?
I do not, but I see some of our I won't name the service, but some other uh, non-medicine folks that I do see that often with like labetalol or hydralazine, for example, where there'll be some PRNs, but I do not.
And so I have this discussion because this is one of those things that I've heard about and has been on my radar for a long time. It's like this is something we overtreat inpatient hypertension. It ended up, and I'll talk to you a little bit more about the points they made it, but it ended up as number one on the list of things we do for no reason. And
Mm-hmm.
the things we do for no reason session at SHM this year,
Yep.
this was their number one thing, was treating inpatient hypertension with PRNs or one-time meds. And so it's the kind of thing that I've kind of heard that, I've been aware of that, but I hadn't been totally up to date on all the data, and then saw this study came out just recently that kind of shined lights on are we just are we just doing it for no reason, or are we doing it for no reason and actively harming
Yep.
patients? Which obviously makes a big difference. If we're doing it for no reason and it drops the blood pressure of the overnight provider and helps save a page and the nurse and all of that, then it's one thing. But if we're actively harming patients by doing it, it's another. And so that's what the study specifically looked in to try and find. And so this was published in JAMA Internal Medicine. It was published in 2025. It was entitled As Needed Blood Pressure Medication and Adverse Outcomes in VA Hospitals. So obviously, this was a VA patient population, but essentially it was um, a retrospective cohort study. As I'm seeing a lot when I'm looking more into methods of these, it was a target trial emulation, I believe. But basically, what they did is they took uh, patients over multiple years, everyone that got admitted to the hospital, and then they eliminated anyone who didn't have any blood pressures over 140 and anyone who never got a single blood pressure medicine the entire time they were there. Basically, I think trying to weed out people who didn't have a significant hypertensive issue. And then they broke things down into patients receiving either one or more PRN antihypertensive versus people who didn't receive any antihypertensive. And what they did pretty rigorously tried to match comorbidities and everything for the patients. And the primary outcome they looked at was acute kidney injury. And then a secondary outcome of two aggressive blood pressure
Hmm.
drops. So they looked at how many of the patients dropped greater than 25% within 3 hours. And then also a composite outcome of myocardial infarction, stroke, or death.
Hmm.
And so the big headline result was that AKIs, all of these things were worse in the patients that got the PRNs. So the AKIs were, I think, 23% more likely to have an AKI. There was a hazard ratio of 1.23 that was statistically significant. A statistically significant hazard ratio of 1.5 for the rapid drop in blood pressure. And anytime you've got a composite outcome with stroke, heart attack, and dying, I'm going to be particularly interested. And was also statistically significant more in the group that got treated with PRNs with a hazard ratio of 1.6. And they looked into these things a little bit deeper. And IV patients that got IV
Mhm.
antihypertensives were even worse, more likely to get an AKI, with the hazard ratio being 1.6 instead of 1.23, versus less, but still significantly significant if they're just getting that oral, kind of like me giving, if I give just that one time carvedilol, that would put me in that bucket.
Yep.
Still showed that there was harm there in the primary outcome. Um, and so that's sort of the big picture of this. And so I found it helpful to see numbers that state if you treat patients or the patients that are being treated with PRN antihypertensive, one-time antihypertensives for an elevated blood pressure, we're actually seeing worse outcomes, which I think it's nice to have this data kind of backing that up. But do you have any initial thoughts or impressions on this?
It definitely made me think back on my nights and try to remember, did I do something for no reason, potentially cause harm? I mean, it's very clear, although it's a retrospective study, it's very clear that giving a one-time blood pressure medication with asymptomatic hypertension causes, at the very least, AKIs, and potential harm for patients. It's kind of my main takeaway from this.
Yeah, definitely. I like I said, it's something I've been trying to do and been aware of, and it's nice to have a study that it's another one of those times where it's almost like a comfort blanket study,
Yep.
that it's like it's okay, you're not making things worse by not doing
Yeah.
anything. I am with you. You mentioned the fact that it's a retrospective trial, and I am on board with this. I am on board that we are treating, in general, almost all of the time, we're treating inpatient hypertension unnecessarily. I'm on board that it's something we do for no reason. Um, but I we haven't had that randomized controlled trial that
Mhm.
really proves it. Because one of my problems with the study and looking through this, I'm like, okay, yeah, I get it. We kind of tried to group patients and balance them like it was a randomized controlled trial, essentially control the patients by making sure comorbidities were the same in each group, and they didn't eliminate very many diagnoses like people had
Mhm.
cardiac stuff, everything. They tried to include a lot of stuff, had a large N, excuse me. Um, but Austin, patients that have an even higher blood pressure, don't you
Mhm.
think they're more likely to get the as needed treatment? So are we kind of just like self-selecting the patients that are
Yeah.
otherwise sicker, and maybe this is correlation, not causation?
Yeah, I saw that with the 140 to 150, one that, like, if you're treating that number, it's kind of like a no duh, it's gonna cause a AKI,
Yep.
but I was yeah.
Yeah, exactly. Yeah, they and I didn't sort of mention that in the rundown, but they did do sort of a subgroup analysis, and that was the only time I saw that in this study they broke it down to just specific blood pressure groups, and that 140 to 159, which you and I are hardly not even tempted to be treating that. It sounds like from our discussion, if you treat those numbers, then you're dropping people who were already not high. I mean,
Mhm.
that's almost normal for I'm stressed out and in the hospital or I'm in
Yeah.
pain or whatever. If you're treating that with an antihypertensive, you're going to particularly see problems, and I get that. But yeah, I agreed. It didn't look like they did any more in their assessment or analysis of this, stratifying how high the blood pressure got.
Yeah.
And so maybe people who are like in the 140s, 150s, 160s, 170s that would have been included in this trial, they're less likely to be getting these antihypertensives, and then if this patient has a blood pressure in the 200s or has something else going on, then we give them the medicine. Automatically, we're putting them in the treatment group we're testing here, and then we're saying,
Mhm.
"Hey, look, they had a bad outcome."
Yeah.
But maybe the bad outcome was the high blood pressure. And now, again, I'm on board, but sort of the contrarian or the I want to be like, is this study itself going to really change my practice and me? I'm I'm a little bit tentative because it's not a randomized control trial. We're not um we may have just correlation here. And that's even they said that in the
Yeah.
discussion. They're like basically they think what this study gives us is more ammo to say someone needs to be doing a
Yes.
randomized control trial that will be the nail in the coffin,
Yeah.
that can really change practice. And we can talk about it on here. We can say 100% you should not be treating it. And we can be changing order sets across hospitals and all of that. But we need that randomized control trial to get there, I think.
Yeah, it gives me more ammunition at night, at very least for these, or if it's below 180, I'm more reassured. Like I don't need to treat this,
Definitely
or
not.
at least don't do a one-time dose. Come up with a better plan and try to implement that in the daytime, and sign that out. But I agree, it's not for the ones over 180 because I don't have that randomized control trial. Um, and I was a bit surprised that just like a one-time dose caused AKI and even in like the above 180 group. I don't think it'll change my practice yet of treating those one times. One, because we don't have enough data, and two, trying to have buy-in with nursing and patients when their blood pressure is over 180 and we're not doing anything. It's an uphill battle that we can't win just yet, especially at night. We kind of need to have a better plan, but it does promote, you know, daytime, come up with a plan. Otherwise, I'm going to keep getting messaged about this and then potentially have poor outcomes with AKIs.
Yeah. And I'd say this kind of similar to the study backing me up, making me feel more comfortable that I'm not like it is reassuring, even with its limitations. It is reassuring that you're not causing harm by holding the line and not treating
Mhm.
asymptomatic hypertension. Now, obviously, we're not talking about hypertensive emergency. If the patient's got a terrible headache, is having chest pain, is having this bad shortness of breath along with it, if we're seeing a flash pulmonary edema, if we're having an AKI, any of that end organ damage, totally different bucket. You need to be
Mhm.
treating that blood pressure. But for the patient that is asymptomatic hypertension, that, along with the AHA guidelines, there were new guidelines from 2024, and that's basically do not treat asymptomatic elevated blood pressure acutely.
Mhm.
And specifically mentioning treatment should generally be the exception and not the rule.
Yes.
um, which is which is how I try to do practice. But like I said, when the number gets to where it's starting with a two, it's hard for me not to be say that's always the
Yeah.
exception, rather than the rule. But I don't think I honestly think that's more me being weak willed than it is me being doing things that's evidence based. And so this is somewhat helpful, this study. And I mentioned that session with the things we do for no reason session at this most recent SHM conference. And it was a really good session, and they gave a compelling argument. I think it was a 2018 article they put out
Mhm.
about things we do for no reason treating acutely treating inpatient hypertension. And they made a good argument. Again, we didn't have that randomized control trial, but a couple of things they mentioned that were somewhat was compelling were there was one outpatient study that they mentioned where essentially it was folks in the office looking to see if they come in and in the office they have a blood pressure of systolic of greater than 180, greater than 200. I think they even went up to they had a cohort that was greater than 220. And looking at if you send those patients to the hospital or if you send them home, how likely are they to have a cardiac event? And I think it was the next 30 days. And there was no statistically significant difference between the two. So this
Wow.
person who's at home and you're not treating this number, obviously, you're not treating acutely, is doing just as good as the person who came into the hospital.
Yeah.
Again, not a randomized control trial, so probably a little bit of selection bias of the people who are more likely to have an issue with that hypertension. We're sending to the hospital. But all that being said, we're sending home people with a blood pressure that's crazy high, not actively treating it, and they're doing really, really well.
Right.
Just like your patient, if you've got a patient who's otherwise healthy, it's a guy in his 20s, 30s, whatever, and he's here for a leg fracture and he's just in terrible pain. The takeaway is he's probably gonna do fine. If he was at home, he'd have that blood pressure probably, and he'd be doing fine.
Yeah.
And so we can pretty much ignore that number and just instead treat the underlying cause. Like, let's be treating this patient's pain. And that's the big takeaway is when you get that page, the first thing should be, are they symptomatic? And the second should be, let's look, are there any underlying causes? And if there are, let's treat that.
That's right.
Um, Go ahead.
And that also kind of patients that come in, they're hypertensive, will get calls to admit them all the time at night. Uh, and I have to think back, and I'm tempted just because the number is scary. But then I think back to my outpatient days as a resident, and I say, well, I've had patients that are that high, and I start them on a blood pressure medication. If they're asymptomatic, we send them home.
Right.
I don't, I don't know, I don't recommend they go to the emergency department. So it kind of makes you think back on your practice as well at night and say, oh, maybe I didn't need to treat that number.
Yeah, and I'll try and I'll find that specific study, the things we do for no reason, talk mentioned and make sure it's there so that if you're having that conversation, whenever anyone's having that conversation with an emergency department, they can kind of have that a backup of, with all the risks of a hospitalization, are we really doing this patient a service if we're admitting them purely because of this blood pressure? Presumably they're in the ED for another reason on top of that. Another kind of interesting point they made that I think as much as anything calmed me down. They made a couple of points. One was, there had been a test where I presume they did this with an A line, where they put a bunch of fit guys, let them loose in a gym, and measured their blood pressure during weightlifting
Portable
activities.
A-line.
I don't know the mechanisms of here. I don't know if they're just like
That's
sitting there right by
that's
a machine
interesting.
doing curls, and then like if it's an A line, if they're doing, because I think one of these was doing squats, or no, they did leg press. So maybe they kept their heart at
Yeah.
the same level. But these guys, their blood pressures in a curl reached up to 240 over 160, and when they did leg presses, it would reach up to 325 over 245. So these blood pressures are crazy high. And the point being, your body is made to temporarily withstand very high blood pressure.
Mhm.
They do it physiologically. Um, and so it's not something that's going to cause a problem for us in certainly minutes or even hours. Obviously, we know long-term management of hypertension incredibly important, but short-term, the body is able to manage it. And another thing they did was showed us some like cerebral blood flow curves and how they really plateaued. And no matter how much higher the blood pressure was getting, the cerebral blood flow was pretty uh, constant. But then once you start to overcorrect that blood pressure, it drops off a cliff. And so, explaining what are these bad outcomes we're seeing? If these bad outcomes aren't just the selection bias that I mentioned could be there, that if we're actually seeing these bad outcomes, and I'm confident that a large cohort of these or a large portion of these bad outcomes are from the treatment of the antihypertensives. If you're dropping that blood pressure, then you're dropping them off the curve where then they're not perfusing their brain.
Right.
And so you're certainly causing more harm than good most of the time, particularly if you've got a patient you don't have any reason to think they can't tolerate that high blood pressure. They should be able to tolerate crazy high numbers.
Right.
Though I don't think any of us are letting a 325 over 245 sit.
No. It's where I think we're all kind of starting to find what the answer is and that we shouldn't be treating these blood pressures. It's just going to have to take a lot of teaching and reassurance for both providers as well as with staff and patients, and kind of flipping that narrative of no, we don't need to treat these, and we've got more data that will need to be obtained in order to really make these big cultural shifts
Yeah,
happen.
100%. Yeah, that was another point they made in the session. In fact, they were like, "That's why this is still number one. We think if you're here at this session, this is probably something on your radar already. Like I mentioned, it was with me, like it obviously is with you. That like we don't need to be treating asymptomatic high numbers just because they're high, but." this is worth continuing to talk about because even if I don't do it during the day, then my night colleague who's got 30 pages to deal with doesn't have time to do anything else other than reflexively treating this if the nurse is particularly concerned and is repeat paging him.
Yeah.
Um, and so it takes an institutional shift. And I do think, I mean, if anyone's out there and is starting to organize or can get the randomized control trial organized, I mean, that would, I think, change everything in how well we can sell this on an institutional level, and really change order sets, change institutional policies, change culture, um, with nurses, confidently tell patients because they're as worried about it as anybody.
Hmm.
Like I know, like just you talk to a patient, they're like, "Oh my gosh, I saw my blood pressure
Yeah.
number on the machine. Like, aren't you going to give me something?" And then are complaining the next morning, "No one paid attention to my blood pressure." And you're like,
Right.
yeah, I did pay
It's
attention. We didn't want to do anything, but it's a tough fight to fight, and we need that fully definitive data.
right. And the more that, um, you know, us and staff and nursing kind of tells the patient, oh, it's very high, then more just begets more, and it just goes higher. And now, then it becomes an issue for daytime, nighttime, and it'd be good if we can just reassure everyone.
All right. So what do you think? Is this going to change? Is this discussion and or this trial going to change your practice going forward? And if so, how?
I would like to think it would. I hope that I would continue to hold the line at night. Overall, yes, it'll make me reassured for under 180. We don't need to do anything. Keep steady. And this gives me a little bit more ammunition and more comfortability to say, oh, above 180 as well. Just you know, let it ride at night and come up with a better plan daytime if we think that we've eliminated all other sources of potential hypertension, such as like stress and surgery, things like this, or pain, um, and go from there. So tentatively and hopefully, yes, it'll change my practice for the better.
For me, again, I think I'm more confident now that I when I get that page, I'll say, are they symptomatic? Is there anything else that can be causing this? If there is, I'll treat whatever else could be causing it. If they're symptomatic, obviously the different bucket. But certainly as long as it's under 200, I think I can hold the line. If it's more than 200 systolics, then I'll be having a conversation about the patient specifically and with nursing staff and try to figure out what do we need to do. And so it'll be hard for me not to at least be starting that patient on a scheduled oral,
Hmm.
because obviously, or starting back their home orals, because like obviously if they're getting that high, they need help regulating some because they're not
Yeah,
actively doing leg presses in the hospital, despite the fact that they're under massive amounts of physiologic stress. But if anything, start something light and oral going forward, and keep my eyes open for that randomized control trial
yeah.
that can put a nail in this coffin and really change culture.
Yeah.
All right,
Nice.
you want to?
Hopefully, I hope I hold the line. I can definitely see. It's tough when it's 200s at night, and you're telling them no, it's okay, but then eventually you get worn down.
It's hard. I mean, and everyone knows anyone who cross covers a lot of patients, but particularly at night when you're doing admissions, dealing with someone who's unstable, and you're like 5, 10, 15, 20, however many pages behind that you're trying to catch up and trying to triage. Just doing something is very often easier than trying to have the conversation and trying to convince someone, hey, look at this study that just came out and
Yeah.
read this article in the middle of the night. And so it really does take
Yeah.
a cultural change because you just don't have enough time when you're cross covering that many patients just because of the nature of the job. This is a busy, tough job.
It makes me more selective though with my antihypertensives. I know which ones are going to peak a little faster, a little
Hmm.
and hit a little harder, because that was another one thing that the article alluded to, which is dropping it within 3 hours. The blood pressure within 3 hours led to some of these adverse events. So I'm more, you know, maybe it gives me more reason to not be so aggressive at night and start maybe a 24-hour drug, and have the day team continue it if they agree.
What is your go-to, treatment if you're getting this page in the middle of the night?
Oh man, before I would be tempted for like Iserdil or
Mhm,
even hydralazine because it's I know it's faster. It's gonna reassure everyone. But now I'm gonna start reaching for nifedipine
mhm.
longer. It's 24 hours. It's got a uh, great plateau with it. So that would be probably my go-to.
Yeah, I've that's been something I've been using more and more, particularly in patients that you're like, you don't wanna drop blood pressure, because I mentioned carvedilol is another one just because it works
Hmm.
relatively quickly. So you get some effect in a time frame that's gonna make people actually feel better, or, make me feel like I'm not just doing something to do something, because I don't,
Hmm.
even if I am doing it for no reason, I don't wanna admit it. So if I'm treating it, I'm not gonna
Fake
give
it
them
till you
5
make
of
it.
amlodipine in the
Yeah.
middle of the night. A
Expect it to
little
do
bit,
it.
because yeah, because even if I'm doing it for no reason, I won't admit that to myself, so I'm not gonna give them something that's not gonna change their blood pressure on
Hmm.
any, time course that's less than days. So, um, but yeah, I like that. Do something that is, if you're gonna do something because you feel like the patient particularly needs it, because the number gets so high, or because of a comorbidity or whatever, that you think the patient really needs it, doing an oral, doing something that's going to work over 12 to 24 hours rather than that quick acting medicine, it really is going to help patients, and you are going to have better outcomes and less kidney injury, less
Mhm.
strokes, less heart attack, less death.
Perfect.
All right, you want to talk about our next case here, our
All
trial here?
right. So next thing, kind of keeping with, things maybe we do for no reason. So this is a article called Associations Between Antibiotic Use and Outcomes in Patients Hospitalized with Community-Acquired Pneumonia, but with positive respiratory viral assays. So this was a really cool article that infectious disease seem to have done in response to ATS, American Thoracic Society. And I like it when you've got two different societies that don't agree, and then one of them decides to try to prove the other wrong and
Right.
kind of clap back with it. So it was a good article. But this is so like I said, it came in response to ATS guidelines who recommended to treat with antibiotics even if there was a positive viral um, assay, claiming that it would decrease mortality, decrease poor outcomes because of the rate of, they felt that there was a high rate of bacterial co-infection with these viruses. But infectious disease seemed to disagree, and they endorsed more low co-infection rates, as well as there's no such thing as a safe medication, including antibiotics. All of these things had adverse events, and that can include AKI, drug rash, etc. So this article was a retrospective multi-center 5 hospital study over many years, 2015 to 2024. And there uh, they sought out patients that had a positive respiratory viral assay within the first 48 hours of them being admitted, and then had clinical signs of pneumonia. So, tachypnea, hypoxia, chest imaging that was concerning for pneumonia. And then they decided to see whether or not antibiotics made a difference in their clinical course from either a very short antibiotic of 0 to 1 day or full cap treatment, which is 5 to 7 days. And the headline here was it didn't make a difference. You could not treat them with antibiotics, or you could treat them with antibiotics, and it didn't make a significant difference in the mortality. Didn't make a difference in the ICU admission rate after 48 hours or length of stay. So it kind of definitively said, no, we don't think so. We don't think treating these patients with pneumonia symptoms with a positive viral assay makes a difference. So disagreed and got kind of two differing societies now, and now it kind of leaves us in the middle of with being internal medicine primary for these patients, deciding on what to do. What
Yeah.
was your thoughts?
Yeah, this was fun, and like I said at the top, like, we're addressing a controversy here, and, it's a little bit nerdy for this to be like, "This is drama and controversy,"
I know.
but
It's about as high drama as it
this is
gets.
about as high drama as, evidence for inpatient medicine gets, so
Yep.
boom, we're excited today. Um, but this was another thing that I heard mention of, at the SHM conference, that there was a updates in the guidelines talk, and they had this little graph that was like a bridge, and it was the IDSA and the Thoracic Association agreeing on guidelines and putting out guidelines together. And then it's like all of a sudden schism and things are breaking and they're going different ways. Um, so it's dramatic. And um, I think this is really helpful to say, this is an impressive feather in the cap of the IDSA to say our recommendation that we do not routinely recommend antibiotics for folks that get admitted for pneumonia and have a positive viral panel. I think this is backing them up pretty well.
Hmm.
Um, the question I have on it, though, is how much is this changing our routine and our day-to-day practice? What are your thoughts? Before we read this article, before we looked at this drama with the guidelines, what would have been your go-to? You've got someone who fits in the inclusion criteria of this study. So you've got someone you admit, are hypoxic. They said less than 95 on room air. So maybe they're on a little bit of oxygen. Maybe they're on a lot of oxygen.
Hmm.
Maybe they're on no oxygen and just sort of flirting with that less than 95. They're tachypnic. And the inclusion criteria was chest imaging was ordered, but they didn't do any assessment of that
That's
chest
true.
imaging. So you get that patient and you're admitting them to your service. And I mean, I'll pretty much guarantee you they're going to that's part of why we do 0 to 2 days, I'm sure, is they've gotten a dose of ceftriaxone and
Without doubt.
azithromycin or something in
Hmm.
the ED. But if you're admitting that patient going forward, are you continuing them on antibiotics, or were you not before reading this, before doing it?
Before reading this, and there was a patient I had pretty recently, 30-year-old, relatively healthy, no other comorbidities, had a bad viral infection, diagnosed it right away, and he was tachycardic in 120s, hypoxic, needing a few liters, and decided not to continue antibiotics
Mhm.
from the ED. And to try and explain that to patients as well as family when they look that sick, goes back to there's no such thing as a benign medication. Everything has adverse effects. So before I was not doing it, was not treating, these patients with a positive viral culture unless something in their story made me suspect superimposed bacterial infection. So I would not be treating it. This just gives me more ammo to really say,
Definitely.
and more comfortability to say it doesn't matter. He or she could get worse in the hospital, but that's why they're here. Closely monitor them, and if they go to the ICU, giving antibiotics would not have changed their trajectory, and they'll be continued, monitored there. Um, so it was really reassuring, and um, just gave me more support for and more things I can tell the family, and why we're doing what we're doing.
Yeah, I'm with you. My practice pattern before hearing about the schism and the drama with the guidelines, or before reading this recent study, was similarly, if I had that patient, otherwise healthy, has a positive viral something, um, whether obviously COVID kind of changed anything, and that's part of the context of this, is we
Mhm,
had so many viral pneumonias at that time that um, we're learning so much more about them, and we were trying different things, and we weren't treating it with antibiotics because
mhm,
I never treated anyone with COVID with antibiotics unless I really thought they had a bacterial superinfection. Um, and they didn't do any better or any worse.
Yeah.
But I similarly, I was practicing similar to you that if I didn't have a reason to, and I thought the virus was the reason for their pneumonia, I wasn't routinely giving antibiotics. That was honestly in a little bit of state of ignorance because looking back, it looks like the 2019 guidelines that were the IDSA
Mm-hmm.
and the Thoracic Association together said give antibacterials if you're admitting someone for the flu or something to that effect. And then
Right.
it wasn't until this post COVID, I don't really know why the Thoracic Society decided to go
Decided to
so much
break
more
off.
extreme. And then the IDSA like almost took that window to not even recommend it in the
Yeah.
flu. Um, so going forward, who do you think's which path are you going down? Are you team Thoracic Society or are you team ID Society?
100% team ID all the way. Whenever we have a tough case or a tough question, we always turn to these guys because they're some of the smartest people. And now we're going to choose not to listen to them. No, I think we're on team ID, and I'll continue to feel support with this article. And continue to not give these guys antibiotics if they have the positive viral assay.
100%. 2 for 2. We're team IDSA. Inpatient Update officially disagrees with the recommendation that you give all patients you admit with positive viral panel and respiratory symptoms antibiotics. And I think this study totally backs me up because
Yeah.
I mean, before we had this study, I would have said these experts say this, these experts say this. It's hard to say. I don't know. Maybe I'm going to go the more conservative route and give
Yeah.
everyone antibiotics. So I really do think I'm glad they did this study, and it totally puts me in the bucket of, to be clear, the guideline of not routinely recommending. And now,
Mm.
again, similar to our other study, this trial has its limitations. This is not a randomized controlled trial; it's
Mm-hmm.
retrospective. And
Right.
so, similarly, I think there's some degree that the patients could have self-selected that sicker patients are going to end up more likely to get the antibiotics.
Yeah.
And so seeing that the patients, and so it makes things a little more complicated there.
Mm-hmm.
If I have a patient and I don't do much critical care, but if I had a patient that was in the ICU, it would be really hard for me if they had something like a non-COVID coronavirus and they got admitted to the ICU with respiratory failure because they don't put a limit on to what I saw, they didn't put a limit on the amount of hypoxia.
No.
Like these people are sick as stink. Honestly, any of these people, if you end up in the ICU, it's hard to imagine you're not getting antibiotics and getting that conservative treatment. Because similarly, not only did they didn't do better with antibiotics, they also didn't do worse with
No,
antibiotics.
they didn't.
This was all no statistically significant changes, including like rates of C. diff and all of that. And so,
Mm-hmm.
yes, there are complications with antibiotics, but we're not seeing that those patients do worse off.
That's right.
And so I if I have a patient that I think is sick enough or just sort of my ears are perking up that I don't think the virus is explaining the whole story, I certainly will give them antibiotics if I think they need it. And frankly, kind of be reassured that I know I'm maybe not causing harm because it's
Yeah.
50-50. And so, I mean, there's only so much power when we're treating an individual human being that is right there in front of. I do want to be a good steward of antibiotics,
Mm-hmm.
but honestly, in my day-to-day practice, what I care more is what's going to be best for my patient.
Yeah.
So if they don't need antibiotics, I won't give it to them. But if they seem like they need it, I'll give it to them. But definitely not routinely giving everyone who comes in flu, COVID, RSV
Mm-hmm.
antibiotics if I don't think they have a
Yeah.
bacterial pneumonia. Like
Yeah.
I wasn't doing that before.
Yeah. It all just depends on the patient that's in front of you. And that's basically what this guideline now gives us. It says, well, we're no longer bogged down and have to give these guys antibiotics if we don't believe it's clinically going to help them or it's going to change their outcome. One thing I really liked about this study, and we keep saying, oh, it's retrospective, but they didn't pull any punches with who they selected. They
Right.
over 30% of them on the initial selection went to the ICU. And then on the continued, after being excluded for procalcitonin elevation and short stays, these guys were still, over 20% of them still went to the ICU, no matter if they got short dose of antibiotics or longer dose. These guys are pretty sick, and I think this kind of speaks to we're learning more about viruses and how sick a person can be with just the virus.
Sure.
Um, and I think that's partly because of COVID times.
Definitely.
And then partly because we're seeing almost any virus can do this. There's some in the study they say they note adenovirus um, and what was the other one? Adenovirus and like rhinovirus,
Mm.
over 90% of them got antibiotics because we keep thinking, oh, I don't think this virus can cause this. But now we're showing in this study, like, no, these viruses can make you pretty sick. And giving them antibiotics just because it's a quote weaker virus may not make a lot of sense. So it's an interesting division that we have now.
Yeah. Yeah. Yeah, to your point and kind of to what I was saying earlier, like I was that guy that probably if it's adeno or rhinovirus and I've got someone who looks sick enough, I'm saying, yeah, I think
Yeah.
maybe there's a bacterial component to this. I want to treat it. And certainly if I'm seeing something that doesn't look viral on this chest imaging that they didn't review, if I'm seeing a
Hmm.
good low bar pneumonia, I'm saying
Oh
that's
yeah.
probably not the virus. That's probably bacterial because there's no good way for us to know is it bacterial or not.
Yeah.
We've got a great way to know is there a virus there.
Yeah.
And so, yeah, to your point, rest on that. Like, trust the viral panel if it's positive, unless you've got a good reason to do antibiotics. Holding off on antibiotics is going to be just as good as for your patients. I'm sure the IDSA would have loved to see that the patients without antibiotics actually doing better from at least either like a length of because I expected to
Yeah.
see like I was looking at like the C. diff numbers and the length of stay numbers and thought
Hmm.
like if we're not giving them antibiotics and tying them to
They
that,
should.
are they getting out of the hospital quicker? Yeah, none of that. All of that
Yeah.
it was 50-50.
They were definitely looking to find something to really showcase. Oh no, you should not be giving these guys antibiotics when they were looking at the AKIs and the C. diff. They
Right,
were
yeah, no,
really
totally.
they were really looking for it, and I imagine disappointed when it didn't pan out. But it again, it gives us internal medicine more freedom, but you just have to be okay with that a little bit of uncertainty, and given that there's two different societies now that are recommending different things, you kind of got to choose your camp per patient, and you're more reassured with this study that you're not blatantly wrong or blatantly going against the current practice-based guidelines.
Gotcha. So I'm hearing you're more reassured. Is this study actively changing your practice in any way going forward?
It's actively changing and continuing to do what I'm doing and not giving these guys antibiotics.
Sometimes no change is a change.
Yes, but it makes me more confident when I can go into the room and tell patients and loved ones, no, we are okay to hold off antibiotics for now, but that's the reason you're in the hospital, to continue to monitor clinically. We don't have a crystal ball to know if there's superimposed bacterial infection, but that's why you're here. If you don't get better, it's no harm to continue to monitor you and then change based on how you do clinically.
Awesome. Yeah, I totally agree. Similarly to our first study, this is kind of what I was doing anyways. If I thought the virus was the cause, I wasn't giving antibiotics, but it's probably moving me on the margin. So, like, I'm going to be that rhino, that adenovirus. In more patients, I'm going to be saying it's going to just that move me that little bit that I'm that much more likely if I've got a patient coming in and I can hang this on a virus, then I'll do it. And then if they get worse or give me any reason, then low threshold to start antibiotics. I'm probably not going to make anything worse if I do,
Hmm.
if I think they really need it. But it will move me that little bit
Hmm.
going forward. All right. Any other thoughts on either of these studies or changes in your practice?
No, we'll just have to see how the Thoracic Society decides to respond and go from there. But I'm interested for the 2026, 2027, seeing, you know, where we all kind of land on this. And hopefully there's going to be a more uh, controlled trial, because now it shows, hey, there's interest, and it doesn't matter how sick the patient is, what their clinical course will be. We should be looking into this for better stewardship and for more ability to take care of these patients the correct way.
All right. So recapping, when it comes to urgent one-time hypertension, acute hypertension in the hospital setting, the data supports you not treating that. In fact, outcomes are worse in the patients that it gets treated with. Um, this is something we generally do for no reason, but we're really looking for that randomized control trial that tells us absolutely it's the wrong thing to do. But we've got enough data that it's clear you need to be thinking about the patient, you need to be thinking about the cause, you need to be treating the underlying cause. And if you're giving something, you should be gentle in what you're giving them, because you're going to cause more harm by dropping a patient quickly than you are by letting them stay at a hypertensive number over the course of hours in the hospital.
That's right.
And when it comes to patients that are admitted with hypoxia, evidence of pneumonia, who have a positive virus, you do not need to do antibiotics in those patients unless you think they actually have a bacterial component. Inpatient update, Dr. Turner, Dr. White, our team IDSA, and we do not think those patients admitted with viral pneumonia routinely need antibiotics going forward. All right, that's it. So thank you so much,
Thank you for
Dr. White.
having me.
It's been a joy. It's been a pleasure. And I'd love to have you on the show again sometime.
I appreciate it. More controversial articles are always fun,
I
so
know
it's a good time.
this was a little bit. I was a little disappointed at the show when I came out, and I'm like, I don't have any. This is the headline, something I was doing before, or you were doing before, that you need to do totally different. But sort of the little bit of controversy in here, and I think these were both really worthwhile articles, and so I was a great
All right.
discussion.
Thank you. Thank you.
All right. And to our audience, thank you so much for joining us. And if you find this useful, please send it and share it with your colleagues or classmates. And if you've got any new evidence you think we should be talking about, and or you are a provider, a specialist, a nurse, a pharmacist, or anyone with value-added insight into the management of hospitalized patients, please reach out to me. You can reach out to me directly or contact Inpatient Update on social media, or email me at podcast@inpatientupdate.com. So thank you so much for being with me, Dr. White, and thank you for the audience. This has been Inpatient Update.